The trauma triad of death, a tactical and clinical imperative in the world of trauma care, whether in a metropolitan trauma center or on a remote mountainside in an austere environment. The survivability of the trauma patient hinges on early recognition and aggressive intervention. One of the most insidious threats to critically injured patients is the trauma triad of death, a lethal combination of hypothermia, coagulopathy, and acidosis. Each component feeds into the others, creating a self-perpetuating spiral that, if not arrested early, leads to irreversible shock and multi-organ failure. Understanding the triad is critical not only for trauma surgeons and emergency physicians, but for EMTs and medics operating in the field, or tactical teams in remote medical environments where definitive care may be hours away. In all contexts, early hemorrhage control is the single most important intervention to prevent the onset of this physiologic collapse. Hypothermia. The silent saboteur hypothermia in trauma is not limited to cold weather environments. Even in urban centers or warm climates, a trauma patient can rapidly become hypothermic due to blood loss, exposure, and impaired thermoregulation. Blood is a thermal conductor. When a patient bleeds, they lose not just volume but heat. Combine this with cold IV fluids, environmental exposure, and removal of clothing for assessment, and the patient's core temperature can plummet below 95 degrees Fahrenheit quickly. Hypothermia impairs enzyme function and disrupts normal coagulation, reducing platelet function and inhibiting the clotting cascade. It also decreases myocardial performance and contributes to arrhythmias. In a tactical or rural setting, this is exacerbated by prolonged evacuation times, inadequate insulation, and limited warming capabilities. In the emergency department, we counter hypothermia with warm rooms, fluid warmers, bear huggers, and rapid infusion devices. In the field, the medic must improvise with space blankets, body heat, passive rewarming, and heated IV bags if available. Preventing hypothermia is far easier than reversing it once it sets in, and it may be the only thing standing between a salvageable patient and one circling the drain. Coagulopathy. The bleeding that won't stop. The ability to form a clot is essential in hemorrhage control. Trauma-induced coagulopathy is complex and multifactorial, but begins early, often within minutes of injury. It is worsened by hypothermia, dilutional effects from excessive crystalloid administration, and consumption of clotting factors due to massive tissue injury. In both urban trauma bays and tactical medicine, damage control resuscitation has become the standard, replacing blood with blood, limiting crystalloids, and prioritizing transfusion of red cells, plasma, and platelets in balanced ratios. Unfortunately, in the field and austere environments, whole blood or component therapy is rarely immediately available. Uncontrolled hemorrhage remains the leading cause of preventable death in trauma, and coagulopathy is a key contributor. The use of tranexamic acid within the first 3 hours of injury has been shown to reduce mortality by stabilizing clots. Pre-hospital protocols in both military and civilian systems now often include early TXA administration, especially in suspected major hemorrhage. In the austere environment, coagulopathy is often beyond your diagnostic reach, but its presence should be assumed in any patient with ongoing bleeding, altered mentation, or signs of shock. Rapid transport, whole blood resuscitation if possible, and avoidance of iatrogenic dilution are essential. Acidosis, the metabolic abyss. The third leg of the triad acidosis is a result of poor perfusion and tissue hypoxia. As hemorrhage reduces circulating volume, oxygen delivery to tissues decreases. Cells switch to anaerobic metabolism, producing lactic acid as a byproduct. A pH below 7.2 worsens cardiac contractility, impairs enzymatic function, and further disrupts the coagulation cascade. Acidosis is both a marker of severity and a contributor to mortality. In an urban trauma center, base deficit and lactate levels are used as resuscitation endpoints. In the field, we rely on clinical signs: altered mental status, weak pulses, respiratory compensation, and delayed capillary refill. Restoring perfusion is the only way to reverse acidosis. This means controlling the source of bleeding, restoring circulating volume with blood products, and avoiding excessive crystalloids. In the austere setting, where diagnostic tools are few, the medic must treat based on mechanism, presentation, and physiology. The spiral, how the triad interacts, each element of the trauma triad amplifies the others. Hypothermia slows coagulation and reduces oxygen delivery. Coagulopathy leads to continued hemorrhage, worsening hypovolemia and hypothermia. Acidosis impairs cardiac output and coagulation, deepening the shock state. This is not a linear process. It is a vicious cycle that can escalate within minutes. Without prompt intervention, the patient's physiology enters an irreversible downward spiral, ultimately leading to cardiac arrest. The linchpin, hemorrhage control. Whether in a level 1 trauma center in New York or a makeshift aid station in a major disaster, hemorrhage control is the most important factor in breaking the triad cycle. In cities, EMS systems may reach a patient within minutes. Tourniquets, pressure dressings, hemostatic agents, and pelvic binders are standard in most advanced life support units. Rapid recognition and early transport to a trauma center enable surgical control, massive transfusion, and resuscitative strategies. Yet even in the city, delays in recognition or improper bleeding control can allow the triad to take hold. The mindset must always be hemorrhage first. In an austere environment, medics must assume prolonged field care may be required. Tourniquets must be applied early and aggressively, even prophylactically, during extraction. Junctional hemorrhages require wound packing and hemostatic gauze. Chest wounds demand occlusive dressings and needle decompression if tension pneumothorax is suspected. Every decision must prioritize. Stop the bleeding, keep the patient warm, preserve what little perfusion remains. Blood transfusion protocols, like walking blood banks, are life-saving, but require training, logistics, and pre-planning. In many cases, TXA and permissive hypotension may be the only tools available to hold the line until definitive care can be reached. Breaking the triad saves the patient. The trauma triad of death, hypothermia, coagulopathy, and acidosis is not just a theoretical construct. It is a lived reality for medics, trauma surgeons, and critically injured patients. In urban centers, we fight it with blood, warmth, and surgery. In austere environments, we fight it with grit, training, and prioritization. But in both cases, the first step is the same: control the hemorrhage. If you stop the bleeding, you buy time. Time to warm the patient. Time to resuscitate. Time to get them to definitive care. If you don't, the spiral begins, and even the best trauma center in the world may not be able to bring them back.